My title today is, instead of what he just said, what Doctor said, it's Personalized Medicine is Not Entirely a Scam. The advantage of being third here is that I can ping very nicely off of Diana and Ernesto, who teed up this talk extremely well for me. And what you'll find is there's a certain amount of consilience and concurrence in what we're going to say, but what I want to look at it a little more deeply than your electronic self, but I want to look at your biological self as well. And I want to thank explicitly Mandy Hall for making Jay invite me. This is, he never wanted to do this. He heard me talk once before. He just said, never want to talk to me. Most importantly, though, I'm going to try to change some of your views about personalized medicine. I'm going to try to force feed you some information. I cannot speak as quickly as Diana, and I'm from New York. So I will just hold on to your seatbelts, and we'll see what we can do for this little ride here. Let me talk to you first about genomics. There's a journal in my business called Nature Medicine. It's a very prestigious one. This is from 2006. It's a seminal article from Duke University. It's a very seminal article where Anil Patti and Joseph Nevins, who's a board-certified famous person in my business, developed this ability to look at the genetic material of a person with cancer and predict what's going to happen in terms of their response to therapy. What they're saying fundamentally is, we know your genes, therefore we know you. And although Ernesto talked, I think, very eloquently and convincingly about the wired self, the monitored self, this gets very deep down in it. It says, we know your genetic material, therefore we know you. And in fact, they've put a number of patients through Duke University with exactly this motif. Unfortunately, it's all a lie. And in fact, this is an article, I understand this was on 60 Minutes on Sunday, by the way. I don't know if any of you ever saw that. It's probably on, since most of you are looking at computers now anyway, you can just check on 60 Minutes on Sunday. There was an article, a piece on this. But it appeared in The Economist in September of this year. And what it says is, basically, it's all nonsense. An article that was published in December of Nature Medicine, that same journal, talked about Anil Patti, the geneticist who described this, resigned from Durham, North Carolina Institution in December 2010. Allegations that he manipulated statistical analysis, padded his resume with fake credentials. The padding of his resume is he said he had a Rhodes Scholarship. He didn't. I mean, if you're going to make something up, it's like saying I have a Nobel Prize. You could check that. Why would you do that? Maybe he's not so smart afterwards. But the point is that his science was completely wrong. Now, this is not to say that all the issue of personalized medicine is as flawed as this. However, I will say to you, without fear of contradiction, that this notion of we know your genetics, therefore we know you, is entirely wrong. And that is to the Trans-Kalahari Quintet and Banjo Mosele. Banjo Mosele is this guy here. This concert just occurred a couple of weeks ago in Botswana. My son heads the program in global health education at University of Texas Medical Branch in Galveston, and he was doing a trip back to Botswana where he lived for a couple of years and put his band back together again. So this is new stuff, but the reason I show you this, not to pitch the CD, which is very, very good, by the way, but rather to say that if you look at these 5 people, or just look around, or just the people at your table, and you come from another planet. So I come here from Mars, let's just say, or Houston, Texas, which, by the way, for most of the people in this room is the same thing. And I come here from Mars, and you say to me, all the people in this room and these 5 folks here are all the same species. That's on its face patently false, right? How could these people and all of us be the same species? And in fact, we are so outbred that knowing your genes and therefore knowing you is patently false. However, it's very much like, it's magic. It's like magic dust or Tinkerbell. It's just magic. And most of us don't believe, at least seriously, in magic. What we can believe in is this notion called epigenetics. And epigenetics is the notion that we have your genetic makeup here, and the environment can work on the genetic makeup. And it does it through the chemical process of methylation. I won't have to go into that in great detail. But what happens is you have your genotype, and it interacts with the epigene, with the environmental influences on your gene, and it produces either health or disease. And this is the fundamental mechanism for the vast majority of non-traumatic illness. This is a complicated slide. You know, my father was in the professor of medicine business, And one of the things, he told me two things. Never say, can you hear me in the back? By the way, can you hear me in the back there? And the other thing is never to apologize for your slides. And I'm sorry for this slide, but I wanted to show you the relationship, for those of you who are not molecular biologists, the relationship between the gene and the things that we see, those things that operate in the body that we now call the metabolome. And the reason I bring this up is I want to spend the rest of the time talking about how do we detect and use the information from the metabolome to give you information about your own health, both in terms of prevention and in terms of treatment. Following up on Ernesto, I'm also a public health guy, so I think in terms of what, not only the individual disease, but how does that disease behave in population? And fundamentally, the challenge that comes across to healthcare in this country and now in the emerging economies around the world is not acute disease, it's chronic disease. It's heart failure, it's hypertension, it's stroke, it's emphysema, it's the ravages of cigarette smoking. We have changed now because of changes in hygiene and immunization. People are living long enough to become chronically ill. And so we have to completely reorient from this acute care model, big hospitals, Orlando Regional Medical Center, Lake Nona, Texas Medical Center. We have to rejigger ourselves to move to where the people are and change the disease management and diagnosis and prevention down to a very individual level. And one of the ways we can do that is by leveraging technology. Because we are clearly an evolving species, right? And one of the huge issues that we have to deal with is the shape of things to come. Because if we don't do something about the chronic illness, those of us who survive are all going to look like that. Some argue that we already look like that. Less so here, but you walk into the Houston, Texas, in the downtown Houston, Texas, that's what people are looking like. The way we do that is we integrate discovery, then we have this process of translation. And you may have heard this thing, this idea of translational medicine. I want to propose to you an idea of translational community medicine. The idea of taking what we know about the gene, taking what we know about the environment, taking what we know about disease and population, translating it in a scientific way so that it has clinical utility, so that we have some way not only of knowing this stuff in a Nature article, but also about doing something about it. Let me spend a moment talking about what I mean about chronic disease prevention. This is not the disease that Diana has. This is type 2 diabetes. Similar in name only. It's a completely different mechanism of illness. It's the most common cause of diabetes in the world. And it is also interesting in that it begins many, many years before it's clinically observed. So here, this is a process of about 30 years where you have the defect which begins sometimes in the 20s, even in the teens, and only 15, 20, 30 years later is it manifested that we know about it. But that pathology, the disease, has been going on for a long time. This is where we want to detect the disease. This is where we want to intervene. The only way we can do that now is through new technology, because the old stuff flat out does not work. What we want to do, again, just like Ernesto said, we want to do prediction, prevention, and only if that fails do we want to treat. There is this thing called the golden moment theorem, which does not mean, carpe diem does not mean fish of the day. The golden moment theorem means you have to strike while the iron is hot. Otherwise, you can be in real trouble and left standing as the ship sails away. Yeah, it's one of my favorites too. Let me dwell for a moment on this slide, because this is the nub of what I want to say. That in taking care of people with chronic disease, not only in the United States, but worldwide, we have to create an ecosystem. We cannot do it only by a physician taking care of a patient. I've been doing this for 35 years, this physician taking care of patient stuff. And trust me, I can't live in somebody's refrigerator. So if I'm taking care of a diabetic, you cannot hold me responsible for that diabetic control. I can't live in their refrigerator. Two reasons: it's cold and the light goes off when you close the door. It does, believe me, I've tried this. You have to have an ecosystem of care that involves nutrition, involves exercise. Again, some of the business that Ernesto was talking about. monitoring that, managing to that, setting goals. And you need to have, though, technology is not enough. Technology does not suffice. Technology needs to have a human face. You've got to have somebody along with you on that technology journey who knows you and you know. Every place you go in the world, there's somebody who has expertise in healthcare. If you go to Central Africa, as I have, and you go to villages where you can't get there by car, only on a motorbike because it's a single trail, and you ask, who do you trust to find out about healthcare? There's somebody there. There's somebody, it may be a traditional maternity worker, it may be a physician assistant, it may be somebody trained, it may be just a community health worker, but there's somebody that people know. If you go to rural East Texas and you ask, who do you talk to? Is it a grandma? You know, is it Tia Maria? Who is it that you know that is involved in healthcare? And you cannot change people's worldview about health until you involve those people. So the key is community health intervention. And if we had time, I'll tell you a little bit more about what we're doing in our group about that. But it's fundamental to what we do. So we have a series of sensors that we've developed. There's a reciprocal relationship between a user and the sensor. When I say reciprocal, information goes this way, information goes this way. And it has to be done in a culturally and intellectually appropriate way. It has to be transmitted, it has to be processed, and then it has to also have that community health infrastructure support. What you can't have is the transmission of information and the expectation that somebody sitting at a desk, looking at all that information, going to pick the needle up in the haystack and call you up and say, by the way, if you don't do something real quick, you're going to be dead in 10 minutes. That's not going to happen. It can't happen, and it flat out doesn't work. The key is real-time decision-making at the point of care. And so the sensors in the quantified self have got to give people information, news that you can use today, and it has to have the human face. It has to be low cost, it has to provide early detection, it has to be innovative technologically, and maybe most importantly, it has to honor the individual's capabilities. It has to be sensitive to the individual's capabilities. If we had time again, I'd talk more about this, but we spend a lot of money in our society on things like intensive care units, imaging, transplants, which have high societal costs, but not much in the way of societal benefit. And yet those things that we know that are very, very valuable, sanitation, nutrition, prenatal care, information flow, are cheap, and we don't spend enough on it. And of course, being in that area, I think you should spend all your research dollars on the information flow, but nonetheless, it is something to think about when you look at the machines that go ping in the hospitals that we have today. So what's the new personal medicine? It's getting the right information to the right person at the right time and compelling the right action. And the right action is the action that works for that person at that time. Okay, so I came from Houston, Texas. This is downtown Houston, Texas. This is the Texas Medical Center. A number of years ago, these cranes have multiplied like yeast amoeba that they are. There are 100,000 people who work at the Texas Medical Center. It's now metastasized through several different parts of the city. This, you may know, this is an old picture from NASA when there was a flyby of the shuttle. I know around here this is a familiar sight to you, but you may have seen this before either in person. But the most interesting thing is I have a picture that was given to me really almost in a very secret place that I'm showing to this group here for the first time, which was the last shuttle mission. Just as they were about to land, they flew over the United States of America, and this is the picture that they took. Thank you very much for your attention.